Kia ora everyone, welcome to this Goodfellow Unit Webinar on common questions for men's health consults. This webinar is kindly supported by Mercy Ascot. My name is Dr. Helen Fulcher, I'm a GP and I'm your moderator for this session. We have two expert speakers joining us for this topic. Dr. Andrew Williams, a consultant urologist with subspecialist training in robotics and complex cancer surgery. Andrew is a member of the Ministry of Health Prostate Cancer Workforce and medical advisor for the Prostate Cancer Foundation and Testicular Cancer New Zealand. Also with us is Dr. Simon Van Rij, a consultant urologist and robotic consultant specialist with expertise in MRI fusion technology, laparoscopic and laser whole lap surgery. I hope I've pronounced that correctly. So I will now hand over to Andrew. Welcome and thanks for starting the session.
Oh, thank you, Helen. Yes, my name's Andrew Williams. I'm a urologist at Auckland District Health Board and at Urology Institute. So I'm going to have a bit of a chat about the thorny old question of PSA testing and prostate cancer and the services available. So as Helen said, I'm a urologist, but I have a specialty interest in oncology. Just a couple of things just to know. I am the urology cancer lead for Te Aho o Te Kahu, which is the basically Ministry of Health's cancer arm. Ministry of Health doesn't do any cancer work now. It's all led by this agency and just a few other bits and pieces. But I do have a prostate and I have actually had a prostate test, which is probably worthwhile noting. So, PSA testing is a real thorny area. It has been for a very long time. And the thing that often gets me a little bit irritated when people start talking about prostate cancer not being a significant issue in terms of, people die with it rather than from it. This is some of the New Zealand cancer data. I could probably find some more recent data, but it's all still pretty similar. And this looks at mortality in New Zealand from cancer. So the top is the number of cancer registrations, and you can see breast cancer is the most common cancer in New Zealand, followed by prostate cancer, and this is in Maori and non-Maori men and women. But if we look at mortality rates here, lung, which is a less common cancer, has much higher mortality, but coming in at number 2 is prostate cancer. So although people often think about prostate cancer as being an old man's disease, it is a very high cause of mortality, and there's a lot of people that die from prostate cancer in their 50s and 60s. The other thing that's kind of important to note as well is the disparity between cancer mortality rates between Maori and non-Maori. We can see in the top level here that the incidence of prostate cancer is pretty similar, but the mortality for prostate cancer is much worse in Maori men, and this has been quite consistently demonstrated. The question then comes down to, is there anything we can do to actually stop people dying from prostate cancer? Well, I can sit there going through a million studies, but I think this is not a bad wee summary. This is actually from one of the Royal Australian College of GPs data on prostate cancer. And it just summarized the studies, and the studies aren't very good on this sort of thing because nobody wants to be randomized into a treatment versus no treatment for a cancer. But I'd probably just the best one to look at is the Cochrane review from 2020, which looked at 20 years, and radical treatment either with surgery or radiation treatment led to a 43% reduction in death from prostate cancer and a 44% reduction in metastatic cancer. So we do know that we can do things to actually treat prostate cancer preemptively. One of the problems why there was a lot of data, conflicting data about prostate cancer is these big studies that were underwent. And one of them, which is the one on the left here, is an American study. It was 77,000 men, so massive study, which showed no difference with prostate cancer screening. The problem with this study is in the non-screened group, 52% of them had PSA testing. So it was a very poorly run study. The European study, which is the one in the middle with 182,000 men, you can see here that we only start seeing a difference in the mortality once we start getting past 10 years. And you can start to see the spread between things there. This has been updated and the numbers needed to treat are getting down to the region of 12 and 14, once we're talking about 15, 16 years out. The best study looking at prostate cancer screening is this Goodfellow trial, which was completely controlled. So you couldn't get your PSA tests unless you were on the trial, and it showed quite a much more significant reduction in death from prostate cancer. But once again, this is the problem with prostate cancer trials, and people often assess them too early, is that you didn't have any statistical difference at 10 years, and you're looking at that divergence after that. So we know that in the long term, there is data to say that screening from prostate cancer does lead to a reduction in death from prostate cancer. The problem then is, should we just be including PSA testing? And the problem with this is it's a really tough question, particularly for you guys in primary healthcare, because PSA has basically been accepted by the general public as a screening test, whether we like it or not. It was basically put out there as a screening test without any studies being done on it. One of the things that has changed recently, I used to get up and say, no, there's very little acceptance for prostate cancer screening, but that tide is changing. We've had a reversal from the US Preventative Task Force, who recommended against PSA testing. They've now changed to say that PSA testing should be a discussion between the treating physician and the patient, and also the Royal Australian College of GPs, which were another one that were very against PSA screening, have changed their position on it. One of the things that makes it really difficult is that patients who are diagnosed with prostate cancer always go through the different phases of grief, and they get a bit of resentment there. And unfortunately, it's often targeted to the, could I have been cured as if this was tested earlier? And that's a really difficult sort of an attitude and probably natural reaction that you have to deal with. So basically, that I think nearly all bodies now are saying that PSA testing is reasonable in a patient that wants to be proactive about their care and is accepting that it is a non-specific test. I talk to people it's a little bit like checking your cholesterol for cardiac disease. So you check your cholesterol. If it's high, we're not sure what's going on, sure, you can treat it. But the other thing you're wanting to do is you're saying, is there any cardiac disease in this guy with very high cholesterol? And then you could go on to something like a calcium score and further investigations like that. And that's really the role that PSA testing is now, is it's not a screening test, but it's rather a risk stratifier that we look at. The thing with it is that if the PSA is done and it's high, you're really at a hiding to nothing, not getting that assessed, because unfortunately, we do see a lot of patients that have had PSA tests that were high in the past, and they present later with prostate cancer, and they always question why was nothing done about their PSA test. So I think it's perfectly reasonable not to do a PSA test, but if you do it, it's probably, you really have to do something about it. It's also important to note that probably we'll find PSA testing will disappear. And there was a recent study on, which will hit the news, on first-line MRI screening for prostate cancer, and that's likely to happen in the future. This is some data that was put out in the New England Journal of Medicine last year, looking at the rate of overdiagnosis of prostate cancer. So PSA testing really started in the late 80s, early 90s in America, and you can see that there was an overdiagnosis. It's probably easier if you have a look at just the left graphs, because the right ones are modified statistical sort of changing. You can see here overdiagnosis was quite common, and now it's settling down, and overdiagnosis isn't such an issue anymore. The interesting thing that came out in this study, and this is looking at American men, so black men versus all races, and you could just as easily put Maori men here, as this is the mortality between 1975 and going up to 2020. PSA testing started in the States in about the early 90s. So this is looking at the mortality rate, and you can see the flow-on effect of that in black men who are of a high risk group for prostate cancer, mortality in the US is actually halved in black men. It is a similar reduction in all races, but really this is quite a marked difference in prostate cancer mortality. And it's important to note that our first chemotherapeutic agent for prostate cancer was approved in 2004. So it was at this point here. And the second one was at 2010. And these agents do not have a strong effect. So it's likely that this is being a reflection of cancer being treated earlier. Who do we recommend that we should test? The main thing that I'd just like to highlight is that you should start thinking about PSA tests in people at 40 if they're high risk. You know, first degree relatives is the real ones that you're watching at. So dad had prostate cancer in his early 50s, or brother had prostate cancer. And that ties in as well the family history of breast cancer. So the BRCA gene for breast cancer is also a prostate cancer gene. Maori and Pacific Island heritage, or those that have had a PSA when they're before 50 or it's greater than 1, you should be probably keeping an eye on them a bit closer, because even though their PSA is normal, the average PSA in New Zealand is 0.6. So if you're under 50 and you have a PSA of 1.2, that is high, and your lifetime risk of prostate cancer is high. Most men, though, should be after the age of 50. They should be having PSA testing. And you want to stop at the age of 70 to 75, or if their life expectancy is less than 10 years. This is how we really screen now, which is MRI scanning. Only about 50% of men with an elevated PSA now will proceed to having a prostate biopsy, because about half of them will be excluded from having anything serious by having an MRI scan. So that's one of the biggest differences that's changed our intervention rates and some of our morbidity in terms of investigations. The second thing that we're doing is transperineal prostate biopsy. So in the past, we used to do transrectal biopsy. So this biopsy would be through the rectum. It's often referred to as transfecal biopsy. And we got to the point where we were actually getting mortality from the biopsies. And in 1 year, I think we had 3 deaths associated with sepsis from these biopsies. So now at Auckland DHB and certainly in private, we only do transperineal biopsies, which don't have a risk of infection. And I think that you'll find that probably the old transrectal biopsy will start becoming indefensible as time goes on. And a lot of guidelines now say it should not be offered. One of the other things that's making a difference is treatment. So treatments are completely different these days to what they were in the past. Radiation and surgical treatments have progressed a long way. And we have national data where we look at incontinence and bowel dysfunction rates. And we know now that actually long-term quality of life is stopping being such an issue with this. And probably a lot of the associated things around cancer care have become much more of an issue as we've gone on. So surgery and radiation have their 2 robots, and they've been battling things out. They're both very good treatments. The surgeons, we now progressing to this Da Vinci system, which is basically a laparoscopic robot. So it's a slave unit. So it's a little bit like having hands inside the abdomen. We get 10 times magnification. It makes the whole surgery more delicate and easier. The radiation guys have this thing here, which has just been introduced in private in Auckland, but it will be will work its way elsewhere, which is called a cyber knife, which is it's a robot arm that accurately delivers radiation treatment to the prostate gland. That means you can give much higher doses in shorter periods of time. The other thing that has come along, which has improved things, is our staging. So it's great to identify cancer, but if you actually give them local treatment and you don't find a cure for it, and you can't cure it, you've just created harm by giving them a treatment that hasn't fixed the problem. This is an example of what we call PSMA PET scanning, which we have available both in public and private. This is a study where we got funded from the Prostate Cancer Foundation to look at traditional imaging, which is on the left, a bone scan. You can see there's no signs of any cancer on this bone scan. On the right is one of these PET PSMA scans, and this is the exact same patient, and they have metastatic lesions to the ribs, in the spine, in the pelvis. And you can see here, this is the fused CT picture. This is a deposit of metastatic cancer that wasn't picked up on CT scanning or bone scanning. And these patients obviously would have had harm if they'd had local treatment. So now that we've got better at identifying who needs to be investigated, identifying who needs treatment, and ruling out unnecessary treatment, one of the things that's become more and more of an issue is actually support for these guys. And we as surgeons, we sort of walk in there for about 10 minutes, talk to them, and then we're out the door, and we don't really see a lot of the aftermath of all of these diagnoses. And stress, depression, and anxiety are really a big issue, as is post-treatment morbidity. And we have nurses that sort of deal with that in our practice. And that is one of the areas we're looking at. The other thing is diagnostic delay. If you've got a question of prostate cancer hanging over you for 9 months, which is quite a common length of time in public, that has major impact on your mental health. And we're working on ways to expedite that. And we're hoping that we'll be able to announce a project with that in the near future. This is looking at anxiety and depression in men with prostate cancer at diagnosis. So this is all responders, those that had it detected on PSA and those that had clinically detected cancer. And these are people that actually qualify for a clinical diagnosis of depression. And you're talking at over 15% of these guys have got depression. There's high rates of anxiety and high rates of stress in these patients. It's not a case of that they're stressed about their diagnosis, because a lot of them continue with this depression and anxiety following treatment. And there are some factors that can sometimes exacerbate this, such as hormone treatment and change in hormone levels, but it's something to really keep an eye out for. And it's increasingly become an important part of our treatment algorithms. In fact, we have in our private rooms, we have a nurse that is a trained counsellor who looks after these guys. And it's incredible how many patients she has identified with significant depressive disorders during their treatment, which us as simple urologists often don't pick up on. One of the things I would like to say is if you have any guys with prostate cancer, use the Prostate Cancer Foundation. Even me, who's involved in this all the time, didn't realize that they actually have funding for counseling sessions for patients with prostate cancer. So they can have individualized sessions with counselors. They also run support groups. It's in support groups for the patients, but it's also support groups for the family as well, and particularly support groups for partners who are often quite impacted by this. We also have a lot of more increased specialist nursing support. So patients that are struggling, we do have access both in the public and private system for more nursing support, which is very valuable for these guys. Everyone will go through a period of incontinence or degree of stress incontinence following surgery. And we never used to have physiotherapy available to them, but now in all centres we have physiotherapy available. Often, we'll see these patients, and I look back on my notes, and this is, I've reviewed them in clinic, his continence is wonderful, and then you find out 3 months later that it wasn't. They do tend to, a lot of patients, I'm not sure whether it's the specialist being blind or the patients being positive towards their specialist, but we tend to under-recognize problems with incontinence and when we see them in clinic. So just to be aware that if you're getting someone who's having trouble, you can be referred into a physiotherapist in either public or private, then they will be seen. And if somebody's using more than a pad a day, or it's impacting on their lifestyle, any incontinence, we should be re-reviewing them because we have treatments available. Simple thing you can tell them in the meantime is just go on the internet. The internet's wonderful with YouTube videos and so forth, and there's lots of instructions there on men doing Kegel exercises. They're pretty much exactly the same as ladies doing Kegel exercises, but with some minor modifications. And it's one of the real useful things about the internet these days is access to these sorts of things. Any man that has significant incontinence also will qualify for ACC funding. We know that significant incontinence following treatment is nationally is less than 1%, and that means more than 1 pad per day. So if you qualify in that area, it qualifies for treatment injury under ACC. So just to be aware that these guys don't need to sort of suffer. There's a couple of main procedures. The one on the left is a male sling. It's like the female sort of slings, which are now currently on a pause because of complications, but these male slings don't have that same complication rate. And that's quite a simple procedure we can do to improve incontinence. And then we can do more advanced procedures like this one on the right, this is an artificial cuff, and it's called an artificial sphincter. So it actually works as a sphincter and closes things off, and they basically, a little pump sits under the skin. They can pump the water out of that cuff, and then they pee, and then it automatically re-inflates once they've finished peeing. Sexual dysfunction. We know this is the score, erectile function score. 25 is basically perfect. Most guys, most guys have a degree of erectile dysfunction in this age group anyway, but you can see they really do get a deterioration in their erectile function initially, which recovers. This continues to improve out to 2 years, but there is a sexual dysfunction following both surgery and radiation is an issue. And increasingly recognised as an important area, even in the public system, to undergo treatment. So we do a few things like, if it's a sort of case, if you don't use it, you lose it. So you don't actually have to really even, use your erection, but we like to encourage blood flow into there. So there's a few things we can do here with pumps. We can use aids such as a ring that stops the blood leaving the penis, or we can look at injections into the penis. And although these aren't available in the public system, we have got them available in private, and we are working on getting them into the public system. And you can't even go to the extremes of putting in implants or inflatable cylinders in the penis. And some patients are really happy when they get penile implants. So as I said, there isn't any funding in the public system. All of these patients can easily have PDE5 inhibitors. Even if they don't work, they just get a bit of blood flow through there. That's always a good thing. And it should really be offered by anyone in that private system that's doing any treatment, because you can get specialist nurses that will improve this, and it's really important to get on and try to keep those erections going through treatment. So what I really want to say is, how can primary care help these men? I think really one of the best things that I see that's really we do very poorly is recognising the mental health side of things, and screening for depression and anxiety, and being aware that there are services available. And as I said, I would recommend that Prostate Cancer Foundation. The counselling is one thing, but even the support groups in the community feel a whole bunch of people have gone through these problems together, and some of them do need medical treatment for this incontinence. Now, as I said, us as surgeons, we're always overly optimistic about our patients' results, and sometimes we think that patients are doing well and they're not. So if you recognise a patient that is struggling, and as I said, more than a pad a day is struggling, they should need to be re-referred to us. They can see a physiotherapist, but we would also reassess them, because there are things we can do about it. Sexual dysfunction. Now, these patients can trial PDE5s like Viagra. We do recommend that they have a decent number of them, up to 10 tablets, before they stop using them, because they can take quite a while to start taking effect. And we can do other treatments, more advanced treatments if necessary. So what I'll do now, if it's all right, is I'll pass things on to Simon. Whenever you mention PSA screening and testing, I'm sure there'll be like a million questions, and we can talk about that after Simon.
Well, we could actually go into them, because there's probably about 6 to 8 questions, and just while it's fresh, because there's some good ones. I'd like your opinion on some of these, Andrew. It'd be good. So a gentleman with the BRCA gene, positive, in his late 40s. How often should he get a PSA?
Very much. I would be every year. And I would be, it depends with BRCA1, BRCA2 is different risk profile. BRCA2 is a much higher risk profile, but still every year, I think. And the other thing too is that if they have any trend for an increase in the PSA, I would be MRIing well before the 4 threshold. BRCA genes, so BRCA2 has I think it's a 7 times higher risk of a prostate cancer diagnosis than the general population. And considering that prostate cancer is diagnosed in 1 in 9 to 1 in 12 men, it's a very high risk. So you have to be very, very careful with BRCA2. But BRCA1 has got an elevated risk, but not to the same degree.
Okay. Next question was, if your PSA is 1, greater than 1, if that's a risk factor for young, when should these patients be referred? And what threshold if their DRE is normal? All
I'd say is that the PSA greater than 1 puts them in a high risk factor group. So it just means that you should be keeping a closer eye on them. So every year would still be reasonable for them, and the PSA referral thresholds would still be the same. It's just more that they should just be pricking your ears up that they are one of your higher risk patients.
Do we still need to do a rectal examination? Do I need to do a rectal examination?
Yeah. It's a really good aim. I think the difficulty is if you know what you're feeling for, you will pick up some prostate cancers that you won't pick up on a blood test. If you don't know what you're feeling for, realistically, there's not a lot to add to things.
Sure.
So, you know, as I said, for me, I'd always do a rectal exam because I know what cancer feels like and what a normal prostate feels like. You know, I'd encourage people to do it, but I don't think it's an absolute necessity. And I think the policy of saying that if it's a barrier to patient care, then you shouldn't do it. But but if the patient's accepting of it, then that's fine.
There's a couple of questions talking about, you know, you talked about over the age of 70 stopping to screen, but I mean, is there still a role for PSA in men over the age of 70? Would you recommend, you know, what are your thoughts?
I think I said 70 to 75. It's a little bit debatable in that area. I think biological age between 70 and 75 is probably the issue. You know, a fit 75-year-old's fine, but a cardiac cripple 71-year-old is a different beast altogether. But the biggest role for PSA testing is you're not really talking about screening or opportunistic testing, I should say, rather than screening at that point. You're talking about a diagnostic test. So you're talking about people with bone pain and abnormal feeling prostate, severe lower urinary tract symptoms. Those are the ones that I would be doing the PSA test for. The
questions kind of have grown and grown. Do you prefer normal MRI screening or multi-parametric MRI, as the later is not available everywhere? I think that's the key thing about MRI quality.
Yeah, I think multi-parametric MRI would currently be said to be the standard of care. Biparametric MRI, which is sort of two phases essentially, is probably demonstrating to have near equivalence. But just a standard Joe Bloggs MRI without an experienced prostate radiographer really is probably worthless. It is, we had this debate. We have a very experienced MRI radiologist in Auckland who we actually got to review another centre that was complaining that they felt that MRI was useless. And they actually ended up having 100% sensitivity in finding prostate cancer on the other people's scans when they went through them blinded. So it was purely a radiologist issue. And it is a very technical and difficult area of radiology.
I'll move away from PSA testing after this one. Any specific timing to do PSA test to ensure it's an accurate result?
Look, I think the reality is you never make a call based on one test. And I think that if you've got a surprise on a test or you're thinking about referring someone based on a PSA test, it's probably sensible to repeat it and say, don't ride a bike, don't ejaculate for 48 hours beforehand, all those sorts of things. If you're talking about timing during the day or anything like that, that's not an issue. But there are those classic things that can make it go up a little bit. But in this day and age, to tell you the truth, we don't take a lot of reliance on PSA tests and small changes in PSA tests. It's more MRI based, our decision making.
There was a couple of questions about treatment, and particularly around post-treatment, morbidity. So with one pad per day, should we just do an ACC claim and refer privately?
The easiest way is they should be referred, and the difficulty is that about 30% of men will get secondary detrusor overactivity. Absolutely. So that it won't be stress incontinence, it'll be an overactive bladder. Now they will get managed for that in the public system. The problem is that it needs to be diagnosed before ACC will take it. So I would recommend that they are referred into public, and they will be seen in public. You just say that, post-treatment, greater than one pad per day, significant impact on lifestyle, and we would organise some urodynamic tests to assess exactly what the problem is. And there's no reason why they can't go forward with ACC funding after that. But the problem is if you just send them and then they've got another problem, they're sort of trapped in nowhere land, really.
Is salvage operation easy after radiation treatment?
Sorry, is salvage surgery easy after radiation?
That's yeah.
So there's a few people that do it. I unfortunately are one of the people that does it. It is not easy. Basically what happens is the prostate fuses onto the rectum, and you have a significant risk of damaging the rectum, significant risks of incontinence. It's a very morbid procedure to go with surgery after radiation, and we only do it in select circumstances.
And I think the last one that I might go to here is, are the results of radiotherapy treatment the same as surgical treatment, and do men who have incontinence do they have incontinence with radiotherapy?
you're looking at the first thing is which is the better treatment in terms of cancer outcome. There is no evidence of superiority of one over the other. I think they're both different strokes for different folks. The main difference is that the surgery really, side effects are more urinary system based, and radiation and they're more bowel based, the side effects. So probably the most important, the easiest way of answering this is when you look at quality of life studies. If you look at quality of life in patients undergoing either treatment, the quality of life is the same and for both. And so it really is a case of which side effect profile people prefer and which treatment sort of method they prefer in terms of how they get there. You know, surgery is a short, sharp hit, radiation's milder over a longer period of time. And it's a personal decision, really, but they're both excellent treatments.
Okay. So I'm Simon, another one of the urologists here. And if you're listening and giving up your Tuesday night, thank you very much for doing that. We really appreciate it. And if you're listening to it as a webinar, these are my disclosures. So similar to Andrew, working both here in public and private. As you can see on my face, I've got a bit of a scar. This is me last Thursday morning, just so no one kind of goes, man, that guy looks weird. I spent the day in ED after I fell off my bike and had to be stitched up. So that's why I've got the scar. We're going to try and have a bit more of a deep dive into some of these things, because often they're areas that you don't see very often or may get a little bit kind of brushed over. And so I'm going to go quite into detail. Though you may not necessarily see many, it's good for us to know a bit more about them. So the first one that I'm going to talk about is a patient who I saw last Friday. I'm going to jump. I just also want to acknowledge the inequalities of health we have in the Auckland region, and particularly in Māori and Pacific Islander, and that we should be continuing to find ways to promote. And I feel that there's, you know, particularly in scrotum and penis issues, there is an underrepresentation of these population groups that we see in the clinic. So this is a patient that I saw on Friday. And this is, I suppose, a typical referral that I would get for these kind of patients. I also saw another patient that day. This one was a little bit more interesting. I didn't know exactly how his trauma with the toilet seat came about, and I didn't want to ask if his penis was erect or flaccid at that time. But Peyronie's disease often presents as four things. First, often, and actually the most concerning for a patient, is they may come to you and say, I think I've got cancer of the penis. And it's actually that they developed a plaque or a lump on their prostate, on their penis. But often that is a very concerning and can raise a lot of concern. The second way often is that they'll say, I'm getting a pain when I get an erection, particularly in the shaft. The third may be that they actually notice that their penis is starting to become bent when it's erect. Or the fourth, which we all love, is the patient who comes in and says, I'm pretty sure I've got Peyronie's from my research. And this is an area where people do a lot of research. And so it's helpful for us to be a little bit more understanding. So when they come into the clinic, we feel like we know a little bit more what's going on. Just a little bit about Peyronie's. It's a microscarring condition. It's a progressive condition. So people are often concerned, could it be from was it, is in terms of a progressive rather than being from trauma, because people are often concerned about that. And basically what happens is a microscarring process occurs, which leads to the penis, when it would normally expand, to be asymmetric and cause a bend. And depending where that plaque or scarring occurs will depend what happens to the penis and also the degree. Now, it actually follows a pretty normal or typical life cycle where for about 3 to 6 months, they do have some discomfort, but then with time that will settle, but with time also the bend may get more and usually kind of level out about anywhere from 6 to 12 months. The plaque itself doesn't cause erectile dysfunction, but understanding a man's erectile function behind it will have a big impact on what treatments. So if I see a patient, or if you see a patient, what are the questions that you should ask these? And so the key often, first thing is to find out how long they've had it for. Then about the pain. And often it's about reassuring them, going, hey, actually, yeah, I understand you have pain, but it actually probably will get better. Then the key impact is it interrupting your sexual function? Is it mechanically making it difficult for you to have the sexual activity that you would like? When I'm examining, what you'll typically feel is you'll feel the shaft of the penis and you'll feel a bit of a hard lump. Not all men who have Peyronie's will have a bend or have a plaque, and some men who have a plaque may not have any bend. It just depends on the location. Now, coming back to my point, this is not penis cancer, because penis cancer is a skin condition, and so, but you do want to examine the skin to make sure. If patients are wanting to take this further, it is really important actually for them to take a picture in the erect state. And obviously they're very concerned, and there are some special apps that they can have to try and hide these, because you don't want that to end up on your photos and then your kids to be, looking through it. I don't think there's role for any investigations usually. You can get ultrasounds of the penis, which can show the plaques, but ultimately it's really a clinical diagnosis. So how do we treat it? So most men who come to see you in the clinic, you can actually just reassure them, because if it's not interrupting function, then there's nothing that needs to be done. Often I give the analogy that, there is a bell curve in terms of the bend of a men's penis when it's erect. And obviously it may change with age, but as long as it's working, nothing needs to be done. If there is, this is a scarring process. There is no tablet, there is no vitamin that is going to make this better. And there's actually no evidence that any of these things, can halt the progression. But if they do have pain, anti-inflammatory, it can be helpful. And also just that reassurance with time, it will settle down. There is a number of different things that people have tried to inject into the penis over the years. There was a collagenase that was available previously, but it's actually not available on the market. And basically it involved having to inject into the penis, make it erect, and then what they called molding, which in essence was cracking the penis to try and make it straight. And it was very expensive, and so it's no longer available in New Zealand or Australia. So when do we have to actually refer? Well, I would refer if they have a significant bend and it's actually interrupting sexual function. What do we do? Well, basically we're assessing function, and that's where the picture will become very important, because we can also give an idea in terms of what we think the outcomes from a procedure would be. Because there are risks with surgery, because in essence, what surgery involves most of the time is if the penis has a plaque, this one expands more than this, and that's what causes the bend. And so in surgery, all you're doing is you're basically causing a scar on the other side to straighten it up. And that will cause some shortening of the penis. There are some procedures where you can try and remove the plaque, but the penis job is to hold the blood in, and so you can therefore cause vascular leak and cause erectile dysfunction. Most men, when you give them an option of a straight flaccid penis or a bent erect penis, will choose the slightly bent erect penis. So if we come back to my patient, he had noticed this for the last 6 months. He did have some initial discomfort. It was more bent than it was, but he could still have normal erections and intercourse with his partner. I could examine him and I could feel this plaque at the base. We had a good discussion. I used some diagrams and he was reassured, and he now has gone away. So that, in essence, I think is about Peyronie's. It's probably a pretty rare condition, but it's probably underreported because many men do experience these as they get older. Moving now to scrotal issues. This was another patient that I had on Friday. It was Friday afternoon clinic. So this was I think he was 34-year-old male with ongoing testicular discomfort, and he'd had an ultrasound which showed he had a varicose. He's obviously had a lot of discomfort. He'd seen 3 different colleagues in this GP practice. Now, a lot of this is going to be based on the health pathways. This is the link to it here. And I do think, I'm a big fan of health pathways, and this is referring to a lot of what is in there. From a general practice or primary care point of view, acute presentations, they need to be directed away from the clinic. So if they ring up and say, hey, my son's got severe testicular pain, they don't need to be triaged to see you. They need to be triaged to go to ED. So if they've had pain 6 to 12 hours, they should be going there because it's a suspected torsion until proven otherwise. And for me as a urologist, if I have a person who's had pain within 12 hours, I'd find it very difficult for them to leave the department unless they've had an ultrasound or unless they've had surgery. And so in primary care, you don't have access to either of those. So that's why they need to be sent in. Obviously, from a referral pathway, under 15s go to the ped surge and then over come to the urology service. The other thing to be aware of is that it is actually quite a rare presentation in men over the age of 30. So we just need to be aware of that. Torsion in general, when you have a classic torsion, it's pretty obvious. They have severe onset of pain. They feel very unwell. They vomit. They have this testicle and they need to go to theatre. The other four things that I think that you may see in primary care that would actually need something to be done is one, testicular cancer, and the second is testicular trauma. Now, what I would say about testicular trauma is sometimes if they have a lump in their testicle and they report only minor trauma, it's usually testicular cancer and still until proven otherwise. So often people associate, oh, I bumped my scrotum or something like that. This is what's going on. But often it's actually the early, just that they haven't examined for testicular cancer. But the most common injuries we see for testicular trauma that we're concerned about often happen in many of the martial arts. And what we're worried about is if someone was to actually rupture the testicle, and they actually do need surgery. Most other testicular traumas can actually just be managed conservatively. I'll talk about these other two. The other one, obviously, is this is a urology presentation, but patients don't all just necessarily fit into that box. Be aware that sometimes this could be a hernia and obviously general surgery. What are questions that I ask? So the first key thing, obviously, and this is coming back to basic principles, is what the pain is. We know where it is, how intense it is, and how long they've had it for. As I always say, if you've had pain for more than 24 hours, even if this is a testicular torsion, the testicle has died. And so the timing of how emergent everything needs to be done, the intensity of that can come off. But often what you're trying to work out, is this actually in the testicle? Is it in the groin? Is it in the back? Is it in the penis? Because men can talk about lots of different locations. If there is an associated lump, where is it? Is it soft? Is it changing in size? Has it got bigger? Where is it? From an infection point of view, we want to know, do they have symptoms? Because epididymal otitis could either be a sexually transmitted infection or a urinary tract infection. One thing that we often do see is people post-vasectomy. They can get, bruising, pain, and so it's important to know if that's been the case. And the other is if they've had a previous torsion or surgery in the past, because some may be born with only one testicle, and so you may have to know that. Some may have had surgery to fix this previously. Examining the scrotum, I think, is an important skill that often the hard thing is in medical school and in general, it's very hard for us to get practice on this. My approach to this always, and what you find, and the classic is the 15-year-old boy who will let you see one ball when you need to examine it and will cover up everything else. And so trying to actually get a good examination is an important first step, because you want to examine everything, and often you may need to do some, cremasteric reflex or different things that you need to see both sides to compare. So I always start on the normal side. And I think in my head in terms of what I'm going to feel. I'm thinking of the cord, I'm thinking of the epididymis, I'm thinking of the testicle and how it all lies in there. What you need to do often is you have to use one hand to fixate or hold and the other to palpate. And because what you really want to do, the key thing first off from a testicular cancer point of view, is to palpate the testicle. As I always say, if there's something on the ball, that's concerning. There can be a lot of squishy stuff around it, but the ball is the key thing that we're trying to examine first off. The other thing to say is that obviously the scrotum is very sensitive. I know they talk about transillumination, but I don't know how many of you would have a torch hanging around and then want it to get dirty having been on someone's scrotum. So if you're concerned for testicular cancer, if you are concerned for torsion, refer without. If you look at health pathways, they would say send an urgent referral and then send them for blood tests and request an urgent ultrasound. Not everyone needs an ultrasound. If you do an examination and you can't feel anything abnormal and there are no other symptoms and the symptoms go away, they do not need an ultrasound, because invariably it's not going to show us anything. If you're concerned, do swabs, do the urine samples. So this is the health pathways guidelines in terms of the treatment for if we suspect epididymal orchitis. Obviously, these are continually to change as we have different antibiotic sensitivities. The hardest thing I find is this is interesting in terms of the wording. How do you decide if you think someone's got, STI-related epididymal orchitis versus, urinary tract infection epididymal orchitis. But this is usually what you would prescribe, which again, in general practice, you guys would be very used to prescribing these medications. This is the latest cotrimoxazole is what they recommended if you thought it was a urinary pathogen in 10 days. And often these are dictated, particularly through the public system, through infectious disease. If I ever see a man who's had epididymal orchitis over the age of 50, my first instance to think is, could this be prostate obstruction? And so if I get a referral for these patients, we're working them up from a urinary tract point of view, not so much in terms of their testicles. What if they don't work? So antibiotics actually work quite quickly in these settings, but swelling and pain can last. And so when I see these patients, particularly when we get severe cases in the hospital, I'll advise them it was going to take 14 days for this to go down, and you're going to feel uncomfortable, and you're going to end up lying on the couch for a week. There are a couple of red flags that make us very concerned, and one of the biggest concerns we have under the urology services when we get patients who have necrotizing fasciitis. And those red flags are often the very poorly controlled diabetics, obese patients. They end up in hospital, multiple operations. It can be a very serious, life-threatening condition. If they have severe pain, not in keeping with their symptoms, if there's pus and ongoing fever. So just to remember, testicular cancer, its peak age is actually in this age group, in the younger age group. And yes, we need to get onto it quickly. The other patient that we often get is this one. So the patient who says, hey, I've got this big swelling in my scrotum, what should I do about it? Often also you may have sent a patient off and get a report such as this, which says there's a hydrocele present. The important thing to ask in these situations with the lumps is how much of a pain it is. Does it impact their function? Does it impact their sexual function? Because ultimately, if it doesn't bother them, in general, they shouldn't have any treatment, because any treatment can have potential harm. So if I do see a patient with a lump and then I have to think about, okay, well, what am I doing? Why am I getting a vasectomy? Why am I getting an ultrasound? You do need to ask a question. And in general, if you think there's cancer, you're going to get that ultrasound very easily. The next question, though, is then what are you looking for in some of these other things? Because what I will say is that ultrasound of the scrotum will find lots of little things. And if you look at the report, there'll often be mention of an epididymal cyst, there'll be mention of, a varicose, there'll be mention of all these different things. And it's important to try and explain that in terms of what the actual significance of these are. Because in essence, most of these things are benign. One of the things that I see a lot is men who have varicoles. And what that is just dilated veins on the left side in general. And if you do an ultrasound and you get your patient to do a Valsalva, you will dilate the veins in the scrotum. So often these will be found on the ultrasound, but clinically won't at all be palpable. So as I said, these lesions or hydroceles, epididymal cysts, anything like this should not be treated unless it's impacting their function. The key often discussion I'll have is I'll reassure them these will not become cancer. They're not a risk factor for cancer. And the problem with these often is they'll go, well, why can't you just put a needle into it and drain it? And the issue is that if you just drain it out, it'll just reaccumulate. These are often, from a surgical point of view, those patients, at least they have something. The next one is, well, what about the patient who has ongoing pain, but a normal ultrasound? And this is all about pain management. So it's very much a team-based approach. First off, we need to do appropriate investigations. And so part of that is making sure that they've had a correct examination, that they don't have anything on their urine, that they haven't had any obvious injuries. But it's important to acknowledge that this pain can be very severe, but also often it can be referred from other places. And often most of my time in terms of talking with these patients is really discussing about their pain and talking through the pain cycle. Because ultimately, if these patients have examination, investigations that all come back normal, the ultimate thing that I'll say to them is that the only symptom that you have here is pain. But if we do not treat pain, then pain will beget more pain. And your testicles are some of the most sensitive nerve endings in your whole body. And the second thing about the testicles is that they are constantly moving throughout the day. there is constant feedback, proprioception going between the testicles and the rest of, in the body. Compared to your elbow, if your elbow sits, it sits in place, but the scrotum is moving. And if they're in a car, I see a lot of truck drivers, people who sit, they're moving constantly. So they're getting biofeedback from their nerve endings all day long. And if that's perceived as a pain, it will beget more pain. And so I'm a very strong believer in pain management and avoiding necessarily having to just be medication, but thinking about other aspects of that. I do refer almost all of my patients to see a pelvic floor physiotherapist, because ultimately we talk about tight necks, but tight pelvises and tight scrotums is actually a very common condition. And it's all about, from my perspective, giving these patients the tools. Let's talk about ways that you can control. So when you have these symptoms, hey, tense, relax, distract yourself, go to the gym, all of these different things. And they can be reassured having had these normal investigations. As I often say to men, the great thing about the scrotum is there's nothing to hide. If they've had an ultrasound, if they've had an examination, it's not like we've missed something. It's not like there's going to be an MRI or a CT or something that's going to find something. We've investigated it. Last couple of things, phimosis. So phimosis, or inability to retract the foreskin, can fall into kind of two categories. One is pathological, where it is a scarring process, such as BXO or lichen sclerosis, versus physiological. And the important thing to remember, and I'm not a pediatric surgeon, but the key thing is that it is a physiological process that the foreskin will slowly retract with time. And so not all boys need a circumcision if their foreskin can't retract. And I just saw, even just last week on Stuff, there was another article talking about, the concerns raised by the community around circumcisions in young children. From our perspective, the patients that I see fall into kind of two main categories. The first is a young adult, so may have not ever had problems, but now that they're sexually active, are finding that they may have tearing or blood from the penis when it's erect, or may just be very sore. And so often these are patients where we can trial steroid cream, and often actually frenuloplasty or cutting the banjo string, as I explained to them, underneath the foreskin and at the back of the foreskin, can actually give these guys, take away some of that tension. And then finally, circumcision. But in general, it's a good discussion and people come very informed, and there are a lot of different websites about that. Often I find for a lot of men who've had circumcision as a child, it's more about body dysmorphism or, lack of consent than actually an operation. And from my perspective, I only would ever do a procedure in a setting which is going to bring benefit, because I think that avoids some of those risks. In older men, sometimes it can become more difficult, and particularly if they have very fused foreskins, it can actually go down into the urethra, can make it difficult if they've got long-term catheters. So I'm going to finish there and open it up to any questions.
Thanks, Simon. Yep, there's a few that have come through while you've been talking as well. And the first one here is around the diagnosis of intermittent torsion of the testes.
Yes.
Yeah, and I don't know if you can read that there, but that talks about the examination, point of care, ultrasound scan done in ED was normal. Obviously intermittent's a different beast again. So can you explain your approach to that?
Yeah, I think intermittent torsion is almost kind of a black box of diagnosis of normal ultrasound, but a good history of torsion. And so the key thing is a radiologist will always say, I can only diagnose if there's no blood flow right now, but I'm not sure if it comes or goes. So in general, if the pain's gone away, they don't need anything urgent. But if they have a young child, they have a very good history of torsion, then I would refer them to urology service for a discussion of preemptive PEXI. Obviously, there's the pros and cons of that.
And there's a further question actually leading on to that, where someone felt that a patient who was a boy of 8 who had a torsion head. Yeah, you can read that, where there no obvious signs or not clear obvious signs. And I guess it's just speaking around that communication piece, maybe.
Particularly an 8-year-old child, there's going to be a lot of concern both from the child and the parents. And so it's important to address all of those. And torsion of the epidermal head, again, is a kind of almost a surgical diagnosis rather than a clinical diagnosis.
Further question about negative STI swabs and a negative urine test, so negative results all round.
Yeah.
Can you still get the epididymolysis with those negative results? And I guess are people seeing these people being treated, patients being treated with it despite the negative results?
Well, I think there's two pathways. The first, obviously, is you can have viral epididymolysis, so mumps orchitis. Again, that's more in the pediatric population. In general, there's the patient who has a swollen red ball who has clinically epididymolysis versus the patient who's got testicular pain, actually doesn't really have a swollen red ball, but we've called it epididymolysis. And then, hey, well, just let's give some antibiotics just and see. So I think, often in that acute phase, antibiotics are not necessarily, are often very commonly used, but I think often there's the differentiation between the two.
Thank you. And again, they're coming in fast. So a boy of 10 years old with a phimosis, he can retract his foreskin if it is tight. If he uses corticosteroid cream for a while, it gets easier. But if he stops using it, the problem comes back. No issues with germinating. Would you be expecting a referral for someone like that, or what's the sort of, how long would you wait and see for?
No, I'd say the first question is if there's any evidence of scarring, the steroid is not going to work. So, but I think realistically, if you've got if you're symptomatic and you're failing steroids, you should be referred for consideration of circumcision. And as the other thing just to note is if there's signs of scarring, the steroid isn't going to work and you should be referred for circumcision.
Brilliant. Regarding Peyronie's, any thoughts on the therapeutic ultrasound treatment or versus shockwave therapy?
I think there's a good use of a machine if you've got one in a clinic. I think that there's some interesting ongoing randomized control trials looking in these spaces. And in general, the problem is that it's often in the men who have very mild Peyronie's. And so they're the ones who actually don't need necessary treatment. And so they may get some change, like the traction devices. They're quite archaic, but often they can just manage without. And it's the patient then who have the very significant bend that these things aren't going to work that are going to need surgical intervention.
There's a question on vasectomy. Who would like to take that one? Laser vasectomy versus traditional surgery, risks and benefits. It's not part of the talk that you've covered, but anyone care to comment?
Laser. I've never used a laser for a vasectomy before.
I think the reality is then when you've got a common procedure, everybody's got their own little spin on it. I think realistically, I don't think there's any difference between someone with a standard vasectomy versus a no scalpel vasectomy versus a laser vasectomy. All you're doing is dividing the vas. It's just different sort of spins on the same procedure. I think that by far the most important thing is somebody that does it regularly.
Absolutely, yeah. And so yes, some very high volume centers, yeah.
Okay, brilliant. 35-year-old male only discovered he had a right undescended testes during the GP appointment at the age of 35, was advised to have surgery after seeing a urologist. Hesitant to undergo that surgery, he's never had any issues, doesn't need to be removed or operated on.
So I think the reason why we're talking about operating it is malignancy risk in an undescended testes. From what is basically being suggested here, though, is that you've got a right undescended testes and you've felt it it's been recognized in the GP appointment. If it's palpable, I would be quite happy to leave it in its place if the patient's not bothered by it. The concern is if you have an undescended testis, which is inside the abdomen, and you're never going to feel it if it develops cancer, because these are probably in the region of 1 in 100 risk of malignancy. And a 35-year-old is about in that sort of watershed area. So personally, I'd say that if it's palpable, I would probably be happy just teaching the patient to examine it and keep an eye on it. But if it's impalpable, I'd probably suggest removal. I don't know what you think about that, Simon.
Yeah, no, I agree with that. Absolutely. And that's where I think imaging in these cases is important, because also some people are obviously born without a testicle. Mm-hmm. So, you may have an undescended testicle or, a complete lack of a testicle on that side. And so if you've ruled that out, then that's the key thing. And intra-abdominal, the risk of malignancy increases a lot higher. So that's why we treat them particularly.
Thank you. Standard treatment care for chronic prostatitis?
I'm a big fan of avoiding the term chronic prostatitis because I think it implies that there's a single organ in the body that is inflamed. And invariably, that's not the case. You know, they've had the MSU, it's clear, they've had all of these things. Urologists, doctors like to use that term because it creates something I can give you tablets for. I can give you anti-inflammatories, I can give you antibiotics. When ultimately actually sitting and talking and understanding more about their situation, understanding the triggers, you know, their life, their anxiety, their stress, all these things, which takes longer, but ultimately can actually lead to a better treatment plan for them. And then that brings in that kind of multidisciplinary approach. So chronic bacterial prostatitis is extremely rare. Chronic pelvic pain, extremely common. And so in general, as I always say to these patients, I say, if you had an infection that had sat there untreated for years and years, you would be very unwell, you know? And why should bacteria cause, with no inflammation on your urine or anything, why should that cause any symptoms? So, you know, it's a balance in terms of those things.
And many patients in that group actually get treated by the fact that you tell them that they don't have cancer. That's probably often the biggest thing for them.
Yes. Yeah.
But I think to be the tablets that are routinely offered in people who have problematic thing would be a course of non-steroidals, a course of an alpha blocker, or in select cases, a 1-month course of antibiotics.
Yeah. And actually one of the things, and it's actually, there's more, it's now generic, is some of these patients who fail those is low dose Cialis or tadalafil can be very good in these men. And, you know, I think it's online pharmacy. I've got patients now, you can get 5 milligram daily tablets, I think about $40 a month. So it's still like very expensive, but in some patients who've tried everything, it is something to consider.
But it sounds like the communication is, again, a top priority in taking a wider history in how you communicate, how, you know, the multifaceted management of it, do you think?
Yeah, but very hard in a 15-minute appointment, you know, so, you know.
All right, there. Do you have any advice for someone here who's got a case of probable overuse of steroid around the glands for possible psoriasis and now has some striae and likely thinning of the skin of the area?
What I would say before I answer that is that the penis skin is still penis skin. And so dermatology are experts and general practitioners. You guys are experts in actually managing skin conditions more than as we are as urologists. And so don't be afraid that if it's just on, because it's the skin of the penis, that there's anything different in terms of how you would manage that. In terms of that, I suppose the hard thing is really trying to reduce the amount of steroid that they're using. And then often one of these last ditch efforts is, do they need to consider a circumcision? But in general, I'd usually like them to have tried all the other options before we go down that path.
The other thing I would say is that penile psoriasis is quite rare. And you would question whether or not it might be balanitis erotica obliterans, which is far more common and will respond to surgical management. So I would recommend a referral to a urologist for a review.
And thank you. How often is a right varicocele a red flag for renal cancer invading the renal veins?
Extremely rare. I mean, I think it's more like a traditional, you know, it's kind of like these signs, you know, when we do medical exams and we learn how to look for Osler's nodes or whatever they are, you know.
Yeah. I think if it suddenly turned up in a 50-year-old man that never had it before, then you would do an ultrasound, and 99 times out of 100, the ultrasound would be normal of the kidney. But it's just one of those things that we just check out occasionally. Yeah.
And there's a question around the criteria for surgery with someone with a hydrocele displacing the testicle to the opposite hemiscrotum. I guess, yeah, what would your assessment?
If you go off health pathways, which in these situations, I'm not a big fan of, because they'll say it's got to be more than 5 centimeters. But in general, it's all about impact on quality of life. Because the worst thing I find is you have these patients like a 34-year-old builder who has a large hydrocele and he can't work. You know, he needs a surgery, you know. But the 80-year-old with this, you know, the massive hydrocele who is having no problems, well, he doesn't need anything done. So it's really about the discomfort and the problems that it causes. So if it's causing a lot of problems and you can show that, then I would refer it, because regardless, you know, you have to take that into account.
Possibly one for you, Andrew, about the prostate. What is the incidence of incomplete removal of the prostate after open radical prostatectomy for a localized tumor that hasn't penetrated the capsule?
I think when you talk about incomplete removal of the prostate, it should never happen, basically. But if you're talking about positive margins with prostate cancer is quite different to other cancers. In textbooks, the prostate has a very, defined margin to it, but actually at parts of it, it's a very ill-defined margin. So a positive surgical margin still has about only a 20% chance of local recurrence. So, and if you have like a T2 lesion, which is confined to the prostate that has a positive surgical margin, the chance of local recurrence is probably even less. So in the past, we used to, if there was cancer at the margin, offer patients radiation treatment, even if their PSA was negative. That's been sort of really starting to be clearly shown as be over-treatment now. So in the vast majority of situations, if you've got a positive margin, no further treatment is required. We just keep a slightly higher risk and we just keep an eye on things, that's all.
Brilliant. Thank you. And there's two last questions here. Can we use anti-inflammatories? NSAIDs is an anti-inflammatory for epididymoid quietus. You're nodding away there, Andrew. Yep.
Yeah, good idea.
No source of infection. Yep, brilliant. And scrotal dysesthesia. I guess it's got here. Any thoughts? So I guess how would you approach a presentation?
I think the reality is, to be dead honest, it's scrotal dysesthesia, it's skin dysesthesia. So you'd approach it in exactly the same manner as you would a post-herpetic neuralgia or something like that. And to be dead honest, you guys would know a lot more about that than I would. If you're talking about testes pain and hypersensitivity, once again, it's a pain syndrome often, but dead honestly, you guys would be better at that than I would be.
Brilliant, Simon and Andrew. I think we got through a world of questions there. Thanks to Simon for your interlude in between to get through a bunch. So I really appreciate that. That's fantastic work, and thanks for all your insights today. And I think a big part of that has come down to me, yes, there's all the treatments and the different ways of managing the different decisions you have to make around screening, but a lot of it does come down to that communication. And I think from your point of view and our point of view, that's something that we can all try and work on and do as best as we can. So thanks again. No problem. Look, we will leave everyone to have the evening back, and we'll have Simon and Andrew back again later on, I'm sure, because we love having them as speakers. So thanks, team. Good night.
Thank you very much.
See you guys.